excited, and we want to say thanks to Dr. Fitzgerald for inviting us here, because as you'll see a little bit later in the presentation, Nora has been a huge influence on some of the work that we've done at Parkwood. So we work in London, so we're Canadian. And there's so many Canadian optometrists. When I first started coming to Nora, there was hardly any, and now there's tons. It's so great to see. So we're coming at it from a publicly funded healthcare slant. So the healthcare environment is very different in Canada, certainly with limited resources. It's a completely different structure. So we'll talk a little bit about some of the challenges of that and what we've done to adapt. So this is our disclosure statement that we have no potential disclosures, but we really actually wish that we did, because it would probably mean we'd be making more money. But unfortunately, no disclosures for us. So what we're going to talk about today is we're going to go over post-concussion syndrome a little bit. We're going to talk about our Parkwood Institute model of care and some of the work that we've done and the programs that we've set up. We're going to give you some strategies for symptom management after traumatic brain injury. And we're going to have a particular focus on our Brain X90 program. And so for those of you that were in Clinical Skills 1, you will see some repetitive slides, but remember what we also taught you. Repetition is important for mastery and learning, so it's good for you. Okay, so when we look at brain injury across the spectrum, and these are the stats I pulled from the CDC report to Congress, but remember it's 2010, and we live in a very different world for mild TBI 8 years later. So these numbers are going to be underestimations for sure, but for traumatic brain injury, 2.5 million emerge visits, and 87% were treated and released. So mild traumatic brain injury is our most common, by far, brain injury out there. And if you take that number and figure out, say 20% will develop persistent symptoms, that's the number that you're looking at for there. So that's quite a lot of patients looking for help and needing care. When we talk about post-concussion syndrome, it used to say that it was until 3 months that they would consider persistent symptoms. But with the new Berlin sport concussion guidelines that came out, they say adults who are still symptomatic after a couple of weeks would be considered persistent symptoms, where peds, it would be more after 4 weeks. So they're really tightening the window in terms of what the expectation of recovery is and when we would say someone's more persistent. So it's no longer that we just wait and see how they do. So in Ontario, for our workman's comp, the standard of care was do nothing for 12 weeks, right? They should get better in 12 weeks, and we won't bother investing in them until it's 3 months down the road, right? So that's starting to change finally. It's been slow, but it's getting there. This is a list of the types of things that we see in our patients. I've always been attracted to brain injury rehab because it's so hard. The patients, as soon as I think I'm good at something, a patient walks through the door that I'm like, dear God, what am I going to do with this person, right? There's a lot of variety. It's very interesting. The mild TBI population, they're much more consistent in terms of what they present like. Don't get me wrong. There's a lot of variability. But what I would like to say is there's something specific going on here. And I really don't think they're all searching the internet to find out what the symptoms are and coming in malingering and faking. I just don't buy that story. I also don't buy the story that's often out there that if they still have symptoms after 3 months, it's not brain injury anymore. And this is sometimes what gets told by funders and people who are doing assessments that determine whether patients get funding or if they actually have a brain injury, if they think it's mental health. So patients come in pretty consistently. Fatigue, trouble with sleep, headaches, balance, some have dizziness, lots of them have oculomotor issues or any issues around visual function, usually cognitive issues. A percentage of them have things like noise sensitivity, light sensitivities, things with speech, difficulty in busy environments. I know this list is not unfamiliar to this group. These patients are coming into your clinic as well. What makes me laugh is when we first see people and we say, oh, do you have a difficulty navigating through the grocery store? And they're like, yes, how did you know? The last 200 patients we saw had that. Do you have difficulty following more than one conversation? Yes. How did other people have that? Oh yeah, like the last 300 people we saw. So this is really, there's a lot of consistency in terms of what they're coming and reporting to us. And Dr. Quaid alluded to this yesterday as well, I thought. But part of the problem with mild TBI is if we only look at symptoms, there's overlap because lots of other things live in the brain. and how that presents can be similar. So this is a graph looking at an overlap between persistent post-concussion syndrome. I don't think my laser is going to go all the way. There it is. Persistent post-concussion syndrome versus PTSD, right? Some symptoms are unique to PTSD, some more unique to concussion, but there's a lot of overlap in between. And particularly if you have that dual diagnosis, like in the military population, they don't tend to do as well, and it's harder to tease out, right? But it's not just PTSD. There's an overlap in symptoms of people have anxiety or depression or cervicogenic dysfunction or vestibular dysfunction. So Chuck's presentation from this morning highlights some of that as well. And so depending on your lens, sometimes you're looking for different things and interpreting things differently. This is a slide I put together, sort of what you're seeing in concussion management now is trying to put people into more subclassifications and trying to figure out what systems are involved so we can figure out how to treat those systems and get them better. So this is, I think, a big leap forward from where we were a few years ago. And so, you know, there's physical things that happen, vestibular, things that are more auditory, visual, sleep, mood, or cognitive. And when you look at what that looks like from a symptom point of view, there's quite a large number of symptoms that patients come out. And the vast majority of them live in the brain. These ones in white, you can have headaches that are related and dizziness related to the neck, but that doesn't live in the brain. Same with TMJ issues can happen, and BPPV, like Chuck talked about this morning. But a lot of the rest of what our patients complain about is all living in the brain. It's all about brain dysfunction.